The next two lectures will talk about the treatment of infection. There are many microorganisms that can possibly invade the human body, colonize, begin to take over human tissue, or produce toxins that make us feel really sick. Of course, some infections are fairly minor, annoying. Others are much more serious and potentially even life-threatening. So medications used to treat various types of infections have been one of the biggest areas of improving health and welfare in humans. And we'll talk about these drugs starting now in part 1 and segueing over to part 2. But let's get started. So what do we have to treat infection? We categorize these drugs, of course, according to the type of microorganism. And we'll start in this part talking about antibacterial drugs. We'll also get into a little bit about antiviral drugs. In part 2, we'll talk about the treatment of fungal infections as well as a specific viral infection, HIV. But you have to realize there are also other microorganisms or parasitic infections that are possible in humans. We won't have time to talk about all of these other infections, including the helminthic infections, worms, things like tapeworms. These are also very significant, especially in other countries where sanitation and purity of the drinking water is not as good as in industrialized countries. But we will take a closer look at the bacterial, viral, and fungal infections. And what we will see is that all of these drugs share a common goal, and that is to have selective toxicity. What that means is we'd like the chemical, the drug, to be selectively toxic to the bacterial or viral or fungal cell with minimal or no harm to the human cell. And in some cases, these drugs do that fairly well. In other cases, it's a little bit harder. But we'll always come back to this goal. Is this drug able to achieve it and to be selectively toxic to the invading organism with, again, little or no damage or harm to the human cell? So we want to start talking about bacterial infection. And bacteria are, of course, single-cell microorganisms, and by that I mean they have their own cellular organelles, they have ribosomes, they have endoplasmic reticulum, they have Golgi and mitochondria. They are usually identified by this, or there are many types identified by a genus and species. If we hear a term like Escherichia coli, we're talking about the Escherichia genus coli species. And bacterial cells are different from human cells in certain ways. First, bacterial cells have a much more rigid cell membrane than the human cell. That's because the internal oncotic pressure in the bacteria is much higher than the human cell, and the cell membrane has to be much more structurally reinforced to contain that higher pressure. Bacteria have different ribosomes than human cells. And the nucleic acid metabolism in the bacteria is different enough from human cells that we can take advantage of that. So what we're going to do is classify our antibacterial drugs into one of 3 categories depending on which of those characteristics the drug tends to focus on. So we'll start by talking about drugs that inhibit the cell wall synthesis and function, specifically in the bacterial cell. Then we'll talk about drugs that inhibit protein synthesis, again, selectively in bacterial cells. And finally, drugs that inhibit DNA and RNA function and synthesis, again, hopefully in the bacterial cell specifically. So we're going to start by talking about drugs that inhibit cell wall synthesis and function, specifically in the bacterial cell. And bacterial cell membranes are different from human cells because they contain these structural reinforcements called peptidoglycans. These are basically like the beams or girders that support a building or support a room in that building. And without those supporting units or those supporting structures, that building or that room would not be strong enough to maintain its function. So what we're going to see is some drugs inhibit the synthesis of those units. Others, they're much more direct. They'll actually punch a hole in that bacterial cell membrane. In either case, if the bacterial cell membrane cannot remain intact, it can't keep the internal and external environments separate, and the cell will self-destruct or die. So here we see some of the most well-known antibacterial drugs, things like the penicillins, the cephalosporins. Specific drugs like polymyxin B are going to affect this bacterial cell membrane. And we'll see that shown schematically in the next slide. So here what you see is the bacterial cell membrane, or again a representation of it, where the reddish pink structures are the phospholipids. And bacterial cells do have phospholipids that make up most of the bulk of the membrane. But what you also see is this yellow structure, the peptidoglycan. Again, it's a sugar protein repeating molecule that gives this membrane strength. And sometimes it's in the middle, sometimes it's on the outer and inner surfaces, but most bacteria have this structural reinforcement. So what the penicillins do, cephalosporins, a specific drug called vancomycin, a very important drug, vancomycin, they inhibit the production of these peptidoglycans. And again, if the cell membrane does not have that strength or that reinforcement, it will probably just self-destruct and the cell will die. Other drugs like polymyxin B and colistin, they're more like a wrecking ball. They're going to be attracted to certain phospholipids and simply punch a hole in that lipid bilayer with the same outcome. The cell can't maintain its internal environment and it will probably self-destruct at that point. So some of the original, obviously, antibacterial drugs were the penicillins, and also some of the more famous drugs, including some of the cephalosporins, they work this way. Our second major group are the drugs that inhibit protein synthesis specifically in the bacterial cell. And they can do this because the bacterial ribosomes are slightly different from the human ribosomes. The bacterial cell has a 50S, which refers to the sedimentation rate of the ribosomes within the bacteria. So certain agents bind to the bacterial ribosome, and by specifically doing that can inhibit protein synthesis in the bacteria. All cells need to constantly resynthesize new proteins and recycle their proteins. So if a cell can't do this, it probably isn't going to live very long. So again, here we see some very well-known drugs that work this way. The tetracyclines, erythromycin, the aminoglycosides. They work somewhat differently from each other, but the end result is that they all inhibit the ability of the ribosome to either read or utilize the messenger RNA molecule. And that's what's shown in the next slide. So again, schematically, you see the ribosomes, the reddish structures in the middle of the diagram, and this chain of messenger RNA being read by the ribosomes. And of course, we have the codons on the messenger RNA that will signal the cell to bring a certain amino acid, and these amino acids will become linked together in a very specific sequence to make the necessary protein. But when drugs like the tetracyclines, or erythromycin, the aminoglycosides, chloramphenicol, when they come along, they'll in some way impair the ability of this ribosome to use that messenger RNA message to create a protein. And as I said a minute ago, if a cell can't make new proteins and resynthesize proteins, it can't live very long. So that's our second major group. Finally, we've got this group of drugs that inhibit DNA and RNA function fairly selectively in the bacterial cell. And they can do this because nucleic acid metabolism is different enough in bacteria versus human cells. The enzymes, the metabolic pathways that are involved in synthesizing and using nucleic acids is different in bacteria. So certain drugs decrease DNA synthesis, and they often do this by inhibiting folic acid. And we know that folic acid is a very important enzyme cofactor involved in DNA synthesis. Other drugs, again, much more direct. They inhibit the enzymes that are needed for DNA and RNA synthesis and function in the bacterial cells. We do see some maybe not as well-known drugs, but again, let's take a little bit of a schematic look at this in the next slide. So here are some common examples of drugs that work this way, that focus on bacterial DNA and RNA function. The sulfonamides, and some of you may be familiar with sulfadiazine or silver sulfadiazine, very important in wound care, and some other sulfa drugs. They're categorized in this way. The fluoroquinolones, these are drugs like ciprofloxacin, levofloxacin, and other drugs that have that FLOX somewhere in their generic name. And Cipro, of course, was very important during the anthrax infections that were being promoted by terrorist activities. So maybe not as well known as penicillin and tetracycline, but very important drugs. Other specific drugs like trimethoprim, metronidazole, and rifampin also work this way. So let's take again a little schematic look at how these drugs are affecting bacterial cells. So here's a diagram of the DNA molecule, and starting at the top, cells have to synthesize their DNA. And there are many steps involved in this, and then the DNA molecule is transcribed into messenger RNA. Some drugs, like the sulfonamides or trimethoprim, affect this process fairly early and inhibit the synthesis pathways. Others bind directly to, like the fluoroquinolones, metronidazole, bind directly to the DNA molecule and tie it up in some way, so it cannot function. Others, rifampin, they inhibit the process of transcribing it into messenger RNA and sending that message out into the cell. So, as you can see, they don't all work the same way, but in some way they are impairing the ability to either make or use the genetic code. So, we've just seen three different categories that comprise several hundred antibacterial drugs, and in each case you hopefully got a sense that the drug is able to take advantage of some characteristic of the bacterial cell. But we now have to consider some other features that are very important about treating bacterial infections. So here are some additional features that are something we should consider or that are very relevant right now in treating bacterial infections. First of all, the effect. Some of the drugs we just met are bactericidal, meaning that they will kill the bacterial cell. Right, bactericidal is similar to terms like homicidal or suicidal. So this means that they will cause death. Others don't directly kill the bacterial cell, but slow down its reproductive function or its ability to divide, and they're referred to as bacteriostatic. So it's just an important thing to consider. They don't all directly kill the bacterial cell, but some slow it down, and hopefully the immune system, if the immune system is functioning well, will be able to take care of the rest. Another issue is the spectrum. We often hear the term broad-spectrum antibiotic or antibacterial, which means, of course, that it will be effective against many different kinds, or maybe an entire type of bacteria, like all the gram-negative bacteria, all the gram-positive bacteria, versus the narrow spectrum that, by definition, is much more targeted for a specific type of bacteria. The big issue, however, is this one, that bacteria have spontaneously mutated to develop defenses against the drug, and oftentimes against drugs that are similar to a specific drug. We talk about cross-resistance. This is, of course, the biggest issue right now in treating bacterial infections, that these bacteria have spontaneously mutated, and we sometimes do not have any medications that are effective against that mutated bacteria. It has become resistant. And it's an extensive problem. So we're going to focus a little bit on that now and talk a little bit about the resistance. So we often hear these common resistant strains described by some acronym, like VRSA, which is of course vancomycin-resistant Staphylococcus aureus, MRSA, methicillin-resistant, VRE, vancomycin-resistant Enterococcus, PRSP is penicillin-resistant Staphylococcus pneumoniae, but there are many, many others. Some bacteriologists say they have identified a bacterial strain that is resistant to virtually every drug we have. So this is why this is so critical. We have always assumed that if a person gets a bacterial infection and we can give them the right drug for that type of bacterial infection, it will work. And that is still true if that strain is not resistant. These are some of the most effective drugs we've ever invented, if, again, the bacteria is not resistant to that strain, to that drug. But if it is resistant, it's much, much more difficult to treat, or sometimes impossible. So we have to again consider, how does this happen and what can we do about it? So again, how do these bacteria become resistant to the drugs we have? And there are several common ways or mechanisms. The bacteria can develop drug-destroying enzymes. And again, oftentimes it's a spontaneous thing where certain bacteria have mutated to have these enzymes so that when the drug shows up, it gets destroyed before it can work. Many of the drugs, like the penicillins, must bind to a binding site within the bacteria to begin to work. And if that bacteria alters or masks that binding site, the drug can't get a foothold within the bacterial cell. Some drugs affect specific enzymes, and enzymes are proteins. They can change, and if again they change enough, the drug can't affect that enzyme. Drugs must often penetrate into the bacteria to begin to work, and some bacteria can in some way prevent that drug from entering the cell, so clearly it cannot begin to affect the cell. And a common one is that the bacteria develop pumps to allow the drug to come in and then kick it right back out again, almost like a revolving door on the surface of the bacterial cell. So the drug spends all of its time coming in and being thrown back out, and it never actually has an antibacterial effect. So these are just some of the common mechanisms that can occur as part of the mutation that leads to resistance. This is another example of a type of resistance. And here you see a bacterial cell membrane. You can see the phospholipids towards the top of the diagram. In the middle, we've got this structural reinforcement that we talked about, the peptidoglycan. Towards the bottom, you see these large proteins called penicillin-binding proteins. What should not be present are these little Pac-Man enzymes called the beta-lactamases. These are the enzymes the bacteria has generated to develop resistance against penicillin, as well as other drugs that are structurally similar to penicillin, drugs like the cephalosporins. So when the penicillin or similar drugs enter, the Pac-Man enzyme eats it up before it has a chance to bind to its binding site and exert an effect. So again, another example of a specific way that a bacterial cell can mutate and develop a way to fight off the drug. The question then is, how do we prevent this? And we hear the term now, antibacterial stewardship, which means we have to be better careful about how we use these drugs. And we most certainly have to avoid overuse, especially the broad-spectrum antibacterials. A more narrow-spectrum drug may be better at getting at that entire colony and killing it, even the cells that have mutated somewhat. But if a broader spectrum allows some of these cells to survive, and these cells have changed in some way, they're going to then proliferate and develop into a colony that has this mutated antibacterial characteristic. So the idea is to use a more narrow spectrum drug whenever possible. Maybe take the time to culture and find what type of bacterial infection it is, and then use a drug that is more specific for that bacterium. Another issue is treatment. Can we give drugs along with the antibacterial drug to overcome the resistance? And that's true for some of these beta-lactamase inhibitors. What these drugs do is we can give them with the penicillin or other drugs like the cephalosporins if that bacteria has that little Pac-Man enzyme that's waiting to destroy the bacteria. So this is just one type of treatment, but there are other efforts are being made to develop other treatments to overcome some of these other changes in the bacterial cell.
Press pause and read this slide before proceeding to the next one for the answer.
So we've talked about, again, several hundred drugs that try to affect bacterial infection in a specific way. And as I stressed, if this bacteria is not resistant and we use the correct drug, they're often very effective. In terms of our major concerns, some people are allergic to these drugs. Many people, for instance, have penicillin allergies. So if we're watching for any skin rashes, any problems breathing, or tightness in the throat, or swelling of the tongue, this could be an allergic reaction. We're looking at UV sensitivity, ultraviolet light sensitivity. It's certainly true with tetracycline, but consider it for all the antibacterials. This is a potentially very serious effect that when people are put on these drugs, they're often told stay out of direct sunlight. And again, it's not a minor warning. This is serious. People can get very badly burned if they don't adhere to that. So if we're using any kind of UV treatment, maybe for wound care, and the person's on an antibacterial drug, we have to be much more careful about the use of this intervention. We can help prevent the spread of infection. We can act as a conduit and spread infection from one patient to other for all kinds of infections, viral infections and so forth. So carefully, universal precautions, simple good hand washing, but also sterilizing our equipment, our electrodes, our whirlpools, making sure that we're not acting as this vehicle to allow the infection to spread from one patient to another, especially the resistant strains. And tendon damage. And this is true for the fluoroquinolones. This is a tendon damage that can be severe and even lead to rupture. And you can see a ruptured Achilles tendon here that was due to a fluoroquinolone antibacterial drug. Considering that these tendons are often the tissues that we're trying to strengthen and protect, this is a very important side effect. So we're going to take a closer look now at why this tendon damage occurs and how we might be more alert for it. So we hear about fluoroquinolone tendon damage often occurring in the large weight-bearing tendons like the Achilles tendon, the patellar tendon, but it can be virtually any other tendon. And it can be severe. As you saw on the previous slide, it can lead to rupture of the tendon. The risks of tendon damage are increased in older patients, people who do have renal failure, who are taking anti-inflammatory steroids or glucocorticoids because these also weaken the tendon, and who have a history of damage to that tendon, probably some pre-existing tendinopathy, which is now exaggerated or accelerated by the fluoroquinolone drug. We're not sure why this tendon damage occurs. It may be ultimately due to the oxidative damage, free radically induced at the cellular level. But again, why this occurs and why it occurs in certain people is just not clear. The onset can be rapid. In one rare case, it occurred within 2 hours after the first dose. It's more likely to occur within the first month. You can see 85% of the cases of tendon damage have occurred within the first month of beginning fluoroquinolone treatment. So, in terms of our clientele and our patients, we have to be more aware of this. And any unexplained tendon pain should be approached very cautiously if the person's on any antibacterial, but especially if they're on a fluoroquinolone, or even have been on a fluoroquinolone for the previous several months. Certainly protect the tendon, maybe put the person on crutches or at least a walking boot if it's an Achilles issue, and have it checked out. Again, don't stretch the tendon, and certainly don't exercise that muscle until this has been ruled out as possible fluoroquinolone-induced tendon damage. So we're now going to leave the treatment of bacterial infections to focus on viruses. And viruses are very different from bacteria. They're much smaller. And a virus contains a DNA or an RNA core that is surrounded by a protein shell or capsid. Other viruses have a glycoprotein envelope around them, but this right here is the working part of the virus, genetic material surrounded by a protein shell. What you don't see here are other organelles. There are no mitochondria, there are no Golgi or ribosomes. So how does the virus reproduce? Quite simple. It's going to move into some host cell, the appropriate host cell, and take over, and use that host cell's biochemical machinery to manufacture new viruses. And that's what we'll see in the next slide. So in terms of viral replication, a virus will again find an appropriate host cell and stick onto or adsorb onto the surface of the cell. It will penetrate into the cell, release its genetic material, and then use that genetic material, whether it's DNA or RNA, to, as I said, take over and use that cell to make new viral components. And the symptoms, why are they making us so sick, are often related to the loss of the host cell function or other direct viral effects. And again, certain viruses are fairly minor and annoying, others very, very serious and life-threatening. Schematically, we'll see this process in the next slide. So here you see a host cell, and it could be a GI cell, it could be a respiratory cell, it could be a lymphocyte, depending on the type of virus. The virus comes along, goes onto the surface, adsorbs to the surface of the host cell, oftentimes because there is a receptor for that virus on that cell. It moves in, it penetrates and uncoats. It releases its genetic material to begin biosynthesis or synthesis of new viral parts. And when it's synthesizing these viruses, a lot of times the host cell cannot function. When the viruses are mature, they're released and they go out into the body to infect other cells. Sometimes the host cell continues to function, sometimes it's destroyed in this process of release and maturation. Viruses they're tricky because of this effect. They will wait, they're very opportunistic, they will wait for the appropriate host cell and move in and take over very effectively, very efficiently. Right away you have to get a sense that it's going to be much harder to kill this virus once it has moved into the host cell. In fact, it's often impossible to kill the virus at that point without also killing the host cell. So we see that the treatment of viral infections pharmacologically becomes so much harder than the treatment of bacterial infections. So in terms of antiviral drugs, some general characteristics are they're fairly specific. They often only act on one type of virus or one family of viruses. They typically inhibit the biosynthesis stage, where the enzymes are used to make new viral parts. As such, they are not usually virucidal. They don't usually kill the virus, but they're usually virustatic. They're going to slow down or delay the replication of the virus so that hopefully the immune system can come in and take over and do its job. And that's often true, unless a patient does not have a functional immune system, that they're immunocompromised. But still, the antiviral drug, at the best we can hope for, is again, it slows down the replication of this virus, which can be a very helpful effect, but probably won't all by itself eliminate the viral infection. So what we've done is gone from several hundred antibacterial drugs to really only a handful, relatively, of common antiviral drugs. And I'll just give a list here of drugs like acyclovir, valacyclovir, which are helpful in herpes viruses. Again, just to give you an idea of some of these: adofovir and entecavir for hepatitis B, amantadine and rimantadine for influenza type A, ducosanol for herpes, the cyclovirs, famciclovir, and penciclovir again for herpes, ganciclovir, valganciclovir for cytomegalovirus, very, very powerful virus, often in immunocompromised people. Same thing with foscarnet, cytomegalovirus, and certain herpes. Some of the other Avir drugs like oseltamivir and zanamivir for influenza type A, ribavirin for respiratory syncytial virus pneumonia, very important virus often in newborns, and finally the reverse transcriptase protease inhibitors and a few other newer drugs that we find helpful for controlling the proliferation of HIV, human immunodeficiency virus. Again, this is not a complete list, but it does give you a sense that these drugs, they're not as plentiful as the antibacterials, and they do tend to be fairly selective against certain viruses. And one more time, They tend to be delaying the replication rather than actually killing the virus. Schematically, the mechanisms of the antivirals are shown here. Some drugs do work on the first step. They inhibit the absorption of the drug onto the cell. And again, we'll see this is true for some of the newer anti-HIV drugs. And if the virus can't get into a healthy cell, it can infect that cell. That's a very good step. Others may affect the encoding. Amantadine does this, rimantadine does this. Most of them, however, affect the biosynthesis phase. This is when the virus is manufacturing new viruses. And it uses enzymes to do that. So many of these drugs affect these enzymes and therefore inhibit the biosynthesis of new viruses. Others inhibit the final steps, the packaging and release. So you get a sense that somewhere in this cycle, the drug is trying to slow down the ability of that virus to either get a foothold or even more likely to replicate itself and go out and infect other cells. We want to focus for a minute or two on the interferons. These are small proteins that are produced within the body that play a very important role in regulating several physiological functions. For instance, they help control cell division and differentiation, allowing the cell to function the way it should function. They certainly control certain immune responses. They're a messenger within the immune system that activates other antiviral effects. Given that fact, a possible antiviral role was proposed very early when we learned about these interferons. They're not hard to develop or make. They're simple proteins. And their initial antiviral effect was not very successful. I think because we didn't know enough about the subcategories of interferons. There's at least 3 major interferon families, and each family has several subcategories. So how do they function as antiviral first, and how have we then progressed to get them to use them better in an antiviral role? Let's look at their possible role first in the next slide. But as I said, we're learning and still learning more about specific interferons and how they work. And these drugs are available now to treat certain viral infections. For instance, interferon alpha N3 is useful in viral infections that cause warts or condylarmata. Interferon alpha con type 1, hepatitis C, so a more serious infection. The alpha 2B form is useful in both condylarmata, hepatitis B, and hepatitis C. So you get a sense that these drugs have reemerged as a potential treatment in some pretty important viral infections. And I think this is going to continue. As I said, as we learn more about this and we study it more closely, we probably will see even more use of the interferons and the subcategories of interferons to treat very specific types of viruses. Still, we don't have a lot of drugs to treat viral infection. And the drugs we do have are often only successful in curbing the spread of that infection. So what has been our major pharmacological strategy against viruses? Well, of course, it's been the use of vaccines. I want to talk about that in the next slide. So antiviral vaccines have been our major strategy in preventing viral infection. And a vaccine is typically made from the actual virus. The virus is modified in some way, usually by changing it or attenuating it or partially killing it, so that it still looks like the virus, but it doesn't actually cause the infection. And if you administer that vaccine prior to exposure to the virus, you're basically showing the immune system what this virus does look like, so that the immune system can develop virus-specific antibodies, so that if the actual virus does show up, the immune system is ready for it. And vaccines have really basically changed the course of human history. When you think of the really devastating effects of the smallpox virus throughout the course of history, and how smallpox vaccines have essentially wiped out smallpox as an infectious agent. The polio vaccine, we see pictures of early physical therapists treating patients in polio clinics and how just devastating that virus is to humankind. That the effects of the polio vaccine have just virtually been miraculous. So we have to appreciate this, that these vaccines have really been kind of one of the major breakthroughs in pharmacology. Clearly, we still need certain vaccines. Probably most notably is the need for an HIV vaccine. But still, the vaccines we currently have really have been such huge benefit to humankind. So that concludes our discussion of the first part of infectious agents. We talked about bacteria, we talked about viruses. In part two, we'll look at a very specific virus, that being HIV. Then we'll talk about fungal infections, which are also very common.
Press pause and read this slide before proceeding to the next one for the answer.